So I don't know where you got to.
Should have answered it.
So the blood is going to spill over, and then the blood's going to continue to fill, okay, until it's all full. Okay, once it's full of blood or pus or whatever is in there, then you have to just go get a new one, and you replace it. Okay?
What's this fill of air? You just let it out somewhere?
It's not really going to fill with the air is just going to come out.
Okay.
Okay, so then the question is setup. Setup is really the big thing that takes all the time, okay? So we've got a couple of tubes here. One of the tubes is right over the drainage, right? That's the drainage tube. It's the one that sticks into the patient, okay? It comes with this cover on it. It's sterile, so you don't have to have sterile gloves on to hand it to the doctor. They're standing there with this chest tube in the patient, waiting for you to get everything ready. No pressure. You take this cap off, and then they're gonna hold one end, and you're gonna push the other end in, and voila, and then they leave. Okay? So that's the drainage one, and then we have this one that is gonna go to the water seal, and it's the one that comes with this neat little syringe. And it usually has a line on it. Usually it has a line, you fill it up, and then when it gets to the line, you lift it up, and it's like just the right amount. Most of us just guesstimate. You can grab a cath tip syringe like we use for NGs, and it'll stick right in here. And then you kind of pour some, and then you watch, and then you pour a little more, and then you watch until you get to this 2 centimeter line. If you accidentally pour too much, there's a port on the back that you can put a needle in, and you can suck it out. Okay? And you guys will get to practice all this next week. So that's the water seal one. The other one is the suction one. There's this little cap, and there's a big hole, and you just pour the water in. So the patient has a chest tube for 3 days. What do you think happens to the water? It evaporates. So you started with 20 centimeters of water a couple days ago, and now maybe you have 15. So part of your assessment when you walk in the room, yes, you want to look at the drainage. You want to look at the water seal. It should not be bubbling, because that means you have air somewhere along the way. Right when they first put it in, you might have some bubbling if they have a pneumothorax, because you expect air to be coming out, right? It should tidal, T-I-D-A-L. It should go up and down with respirations. That's normal. And then you're going to take your suction tubing attaches to this, to the wall. You're just going to pinch it to turn off the suction. So this is bubbling. It's like a babbling brook, not roaring rapids. It doesn't matter what it is on the wall. If you have the water to 20, it's supposed to just give you 20. Even if it's, right, and it's bubbling like a jet in a jacuzzi, which is way too much. It should just be kind of a gentle bubbling. But you're gonna pinch, and then you'll see where your water stops, and you'll go, oh, it's at 15 now, so I'm not getting 20 of suction, so I need to add more. And so you just go grab your sterile water, and you just pour some more in. Okay? So that's part of your assessment. So that's all so the suction, you check for bubbling. The water seal, you check that there's no bubbling. And the drainage, you're gonna look at the drainage, and we're gonna mark it as we go. For the open heart surgery, which is the context that you guys are learning the chest tube in, you shouldn't have more than 200 output for 2 hours in a row. That's too much. So if you've got 150 when they come back, you maybe now have 200, and then the next hour you have 200 again or 300, your patient's bleeding. Now sometimes they'll say, just put it to gravity. How do you put this to gravity if this is attached to the wall suction? It's very easy.
You just unhook it.
You just turn the suction off. Gravity. Now I'm at gravity. Because maybe it was sucking too much. Maybe they'll want to give like a reversal agent they get protamine during surgery. Heparin during surgery. So they may need some more protamine, coags, etc., etc. The 200 for 2 hours in a row. But the other thing that can happen is you can clot too much because they're giving that protamine after the heparin. The heparin, so it'll go through the bypass machine. And if your chest tube clots off, you're going to have like 50 and then 20. Like you don't have enough drainage. They just cracked this patient's chest open. There's going to be drainage, right? So if you notice that your output is decreasing a lot over a couple of hours, that's also bad because then all the drainage will build up in your chest and you'll end up with a tension pneumo and it'll push everything over and then you're going to have a breathing issue and a heart issue. There won't be good cardiac output, okay? A couple of other things. So all of the connections we want to tape, but we don't use that pressure, that foam tape anymore because you want to see your connections. So we use that clear plastic stuff and just kind of figure eight it around so you can see because you don't want them to come apart. Troubleshooting. Before troubleshooting, always make sure, just like with the Foley, there are no dependent loops and the Pleurovac is always lower than the patient. So you're going to be always making sure your chest tube is flowing because what happens if your chest tube clots off? You can backflow, get an infection, you can get a tension pneumo. Who gets to fix that? The surgeon. Who's making the awkward phone call to the surgeon? The chest tube is clotted. That would be you, and that is a horrible call to make, okay? Because there is no fixing it without just putting a new tube in. And that poor patient, they had those tubes put in surgery. They didn't know they were having them put in. They're going to have the pain after, but now they're going to suffer the pain of another one being put in, okay? Plus, it can be life-threatening and, all that. So you always want to, every hour on your rounds, this is attached to me, you come in and you're going to drain it and just kind of make the blood all go into the drainage thing and then curl it up on the bed and make it flat. Okay? So troubleshooting. Patient's going all crazy and they pull their entire chest tube out. Now there is a hole in their chest looking at you when you run in the room because they're sat drop.
Petroleum jelly.
Cover
gauze.
it, but there's a way to cover it.
Pressure. Petroleum jelly. Gauze.
It's going to be a sterile dressing, but there's something special about a sucking chest wound dressing.
I think I know. You only tape 3 sides.
Yes. Why?
So the air won't come in and it allows them to.
Right, good. So you're going to tape it on 3 sides. So now it won't suck air in because when it's sucking, it's going to just get the gauze up against them, but the air can come out. Okay? So what if their chest tube is still in, but they've disconnected it? Or you trip over it and it comes apart, if you're me. You're going to take your bottle of sterile water and you're going to just go boop and put it in so it's under the fluid. And you're going to say, hey, I need a new Pleurovac. Mayday, mayday. Okay? What if you're going to go to CAT scan? You're going to hang it on the bed, and then what? Is there anything else you have to do? It's going to be on gravity. You're going to disconnect it from the wall, so now it's gravity while you're in CAT scan. Casey, take it on my 5-minute update room. We're almost done. I'm so sorry. Oh my God, I forgot what time it was. It's fine. We'll end the video.